Hello, this is Dr. Hausinger, and this PowerPoint is going to cover your Babor book, The Management of Pharmaceutical Drugs. So this week, we do not have a lecture on cannabis. You have a lot of resources on cannabis, as well as the film Reefer Madness, which was published in either 1935 or 1936. It's a little debated, and there is a colorized version that came out a couple years later. And then in 2005, there was a version that was turned into a musical with Kristen Bell called Reefer Madness the Musical. If you get a chance to see that, I highly recommend it. It's hilarious. But the point of watching the original film is that it's a propaganda film. They want you to see how it was capitalized on and promoted in the 30s. And then there's one thing in the film that I just wanted to point out that is kind of unique and interesting, and that's a comment that I had gotten from a previous class where someone said, "Why is it that everybody in this film can play the piano?" And I was looking at that because it was really interesting, and it turns out that in American history, most people did learn how to play the piano in the 30s, 40s, maybe even up to the 60s, 70s. It was just something that people did. People had piano lessons, and they weren't necessarily expensive, and it wasn't really a class issue. I remember my grandmother went to Catholic school, and the nuns taught her how to play piano. So if it looks like everybody in the film does know how to play piano, it's because that was a cultural phenomenon, and most houses did have a piano. Okay, so that's your fun bit of American history. So now let's talk about the legal drug epidemic and prescription regimes. Many of your current events have focused on this. We're starting off with something that happened in 2017, and that was the big pharma billionaire. And this was pretty groundbreaking because he was one of the first people that was arrested and had a trial, which started and ended this past January. So it's been going on for a while, and he was basically found guilty of bribing bribing doctors to prescribe fentanyl. Okay. All right. After 15 days of deliberations, a jury in Boston federal court reached the first ever conviction of a drug company CEO and the federal government's fight to combat the opioid crisis, finding the Arizona-based company's founder and former chairman, John Kapoor, guilty of racketeering conspiracy charges. Okay. All right. This is considered a landmark case. Federal prosecutors argued that doctors between 2012 and 2015 provided patients large numbers of the substance fentanyl prescriptions, including to non-cancer patients, in exchange for kickbacks and bribes from the INSYS, that's the name of the pharmaceutical company, executives. Some of the doctors who were already convicted of crimes in the states where they practiced testified against the pharmaceutical company. Okay. All right. Quite interesting. So this, and we're seeing more and more of this coming out too, and I think some of your current events talked about the this happening in England as well. Okay. Right. It looks like the sentencing has not yet taken place, but the sentence could be up to 20 years. Okay. All right. So we know we've talked a lot in this class about geography and different trends, and some of your articles looked at this, and some of the articles that you have this week in Moodle are going to highlight this as well. There is a big problem with prescription pills in rural communities. We know that some of these states, they had billions of or millions of pills sent when they don't have that many people living there. So we see we've had a lot of deaths in Ohio, West Virginia, Kentucky, Tennessee, so much so that the morgues have not been able to handle the amount of people that are dying. Okay. In October 2017, the Centers for Disease Control and Prevention announced that the rates of drug overdose deaths are rising in rural areas, surpassing rates in urban areas. In addition, a 2017 survey by the National Farmers Union and the American Farm Bureau Federation found that as many as 74% of farmers have been impacted directly by the opioid crisis. And this is taken right from the USDA government site. As I've mentioned before, what we're seeing, and some people might argue that some of the tariffs and trade arrangements with this current administration have led to this as well. It's very difficult to be a farmer right now, and it's very difficult. There was actually just an article about West Virginia where a lot of the farms are closing. The coal industry has been, debated back and forth, but farmers are committing suicide at alarming rates. And this one farmer that was interviewed said that somebody commits suicide at least once a week in their small community, which is very shocking. And some of that does have to do with prescription death. Okay. So let's look at the prescription system. So right now we have, you go to the doctor and the doctor writes a prescription and they send it to the pharmacy and then you as a patient get it. Okay. Now what influences this? And then we've seen a lot of work in the last year or so in regards to why are prescriptions so expensive. I believe it was Illinois just capped the price of insulin. Young people are dying because they cannot afford their prices. And you might have seen these commercials lately. There are these applications and internet pages that you can go to where you can price shop for prescriptions because they're not going to be the same depending on the pharmacy that you go to. Pharmacies have deals with different insurance companies where you're going to be able to see a fluctuation in price. For example, the pharmacy that works most with Kaiser is Bartell, so it's probably going to be less expensive at Bartell than if you were to go to another pharmacy. So professional associations, patients' interest groups, marketers, and manufacturers all influence the system. DTC is direct-to-consumer advertising. There's only 2 countries in the world that are allowed to do this. This is why we have prescription ads on TV. That's USA and New Zealand. And wouldn't you know, we have the most prescription use, these 2 countries. Okay. Now, the prescription regime is relatively new, as of 100 years. And they used to have compounding pharmacies, and they still do, where the pharmacist would custom mix up the medication for you instead of having it all manufactured and prepackaged, ready to go like we have now. We first started seeing that in 1914 with opium and cocaine, and that was just a few years before the Harrison Drug Act came into place. And then we have the Food, Drug, and Cosmetic Act of 1938, which influenced this as well. Similar acts which regulated prescriptions. Australia, they had one in 1905, the UK in 1916, and the Netherlands in 1865. Okay. It was not uncommon for doctors just to have the prescriptions at their offices and to give them directly to patients. Now that is coming back a little bit because doctors do get free samples and they have a certain amount of medication that they can distribute at cost and or free. And because Americans cannot afford their prescriptions, many doctors are actually doing this again, and they're kind of fighting back against the pharmaceutical industry in this case. Right. So what are some alternatives to prescription control? Right. Well, medications are only available at pharmacies. Right. So this would be, for example, in Canada, you can get codeine cough syrup at the pharmacy, but in the United States, you can't. I'm sorry, I said that wrong. You have to have a prescription for it, right? You can't just go buy it like you can in Canada. Okay. Medications could be under the pharmacist's eye, which means within eye shot. Okay, so that is a way for them to kind of monitor. Right? Behind the counter means that you can see it, but you have to ask for it, and it might be monitored. An example of this would be not Benadryl, Sudafed, and some of those that are precursors to methamphetamine. Okay. And under the counter, which means that you have to ask for it, but you can't see it. So This is kind of both. It depends on the state or even maybe the town where you're in. And then doctor's letters, like a letter from a doctor saying that you need this prescription. Okay. And I think that we've seen that a lot with marijuana. Okay. So control medications, these would be prescription versus over-the-counter controls. Um, why are some things prescription versus why are some things over-the-counter? There is limited research on switching over-the-counter medicine to prescription. An example of this would be years ago, Claritin had to be prescription, and now it's over-the-counter. Okay. There's an assumption of if it's not prescription, it must not be potent. Yes and no. Some people react very strongly to Benadryl. Some people hallucinate when they're on Benadryls. I've heard stories of children hallucinating on Dimetap, Robitussin. Okay, that's one that we haven't heard about in a while. Robotripping, where people drink Robitussin to get high. Okay. And a question that we have to ask ourselves is, does it remove the substance from insurance coverage and create financial barriers? And that could go both ways. Walmart sells a brand of insulin that is relatively inexpensive that you can get without a prescription at their pharmacy. Whereas we know that prescription insulin, people might be paying $1,000 a month. Okay. So this is an ongoing conversation, and it's probably going to be based on each medication. Okay. Provider controls, okay, seeing the pharmacist as the gateway. And with people doctor shopping and going from provider to provider to get things, this is not necessarily a bad thing because pharmacists do save people's lives when they look up your record or they're like, what other medications are you on? And they see the drug interactions. So that's not necessarily a negative thing. Written instructions don't help with medication compliance. What does help is individual counseling, the pharmacist taking time to talk to the patient, and that increases medication compliance. So if you had a medication filled recently, you might notice that you have to say, no, I don't want to talk to the pharmacist, or yes, I do want to talk to the pharmacist, and you actually have to sign off on that electronic device. Okay. Now, some insurance companies are actually recognizing this and are compensating pharmacists for drug counseling time. So we might be seeing a little bit of a going back in time to things that might have worked previously. Providers and guidelines. There has been mixed evidence regarding guidelines for prescriptions and dosing. This is also true of veterinary medicine. There's a big debate about the amount of vaccines that dogs and cats need. I don't want to get into the vaccination debate, but it's the same for veterinary medicine. Discrepancies exist, good practice guidelines, and actual practice. So what do we recommend versus what is actually happening? And I think that we could even broaden that to the discussion of you have back surgery, you have pain medications for a month, and then they just stop. And there isn't counseling about how to wean yourself off of them. Pain may or may not be gone by then. So there's a responsibility here that needs to be addressed. Washington state dosing guidelines from 2012 have been effective in decreasing opioid prescriptions in worker comp cases. And conflicts of interest are present in direct-to-consumer advertising. It's kind of akin to the Google MD. Now, some people in the medical community have actually spoken up that we create medications for normal things. For example, low testosterone, that's a normal thing that happens as men age. Restless leg syndrome, that can be a normal thing based off of anxiety. Premenstrual syndrome or PMDD, that's a natural thing that happens. It's not necessarily a condition in and of itself. They created a condition so that they could sell medication. Right, so again, I know we've talked a lot about this. This is another issue with our healthcare system and seeing citizens as consumers rather than as patients, right? We're commodities in the healthcare system rather than a medical system where it's a service for the people for our own well-being. Okay. So how do we moderate pharmaceuticals? Okay. So we go back to the word diversion. Diverted means where you take something that was intended for something else and put it on another path. Drug take-back programs are community-based. You can bring them to a lot of pharmacies, but a couple times a year, police departments will take them. Right. Don't flush medications down the toilet. It gets into the water and pollutes our fish and the water. So please don't do that. If you are going to throw away medications and hard drugs as well, what you do is you take the pills, you can crush them up, or you just mix them with coffee grounds and put them in a trash bag and throw them away. Okay. Don't flush medications down the toilet. Tamper-resistant seals can help with medication. There might be the substitution effect of medication. So something that it could be a placebo effect, or it could be something that doesn't have as many side effects. Right? Screening and treatment contracts are important, and we're seeing more doctors do this with opioid patients, where, let's go back to our example of a person that has back surgery. They see their doctor more often. There's a contract. They have to go back every 5 days or so. And it's not just, okay, here, you had surgery, here's your pills. When they're out, you won't need them anymore, but it's more personalized. Looking at system level monitoring, which would be doctors have to turn in their, log in how many prescriptions that they are writing for certain things, and they're monitored there. Okay, and then also going back to the pharmaceutical companies being monitored, why are rural towns getting more pills? Right. Okay. State by state, there might be a provider database that they have to look into. Okay. Safety withdrawals. Right. So how do we do things in a safe manner so as not to encourage underground drug-seeking behavior? And then restricting the number of providers that can prescribe certain substances.